All right, so the next chapter, 33, we're going to be talking a little bit about non-malignant hematologic disorders and how to manage those. First thing we're going to talk about is anemia. Now, remember, guys, we are not going to cover everything in this chapter, and a lot of this is just going to be kind of broad concepts. So I'll try to point that out as I go so that you don't get caught up in the little details. Okay, so anemias as a whole, just a lower number or lower than normal amount of hemoglobin, fewer than normal circulating erythrocytes, can be either one of those. Either of those, lower hemoglobin or less than normal number of red cells, either one of them is going to lower our oxygen carrying capacity. So, neither one of those things is a good thing. Anemia is not a disease of its own. It is the sign of an underlying disorder. So it's a symptom. Okay. So if a patient is anemic, they have another problem. Okay. They're classified according to whether or not the deficiency is caused by a defect in the red cell production or by destruction of red cells. So a defect in red cell production is known as hypoproliferative, meaning they are not developing, they are not mature enough. There's something wrong with the production of them or development of them. And then hemolytic anemias are the result of destruction of red cells before its time. Okay, so hypoproliferative anemias have to do with can be iron, B12, folic acid deficiencies, lack of erythropoietin. It can be related to cancer, but it's a situation where the bone marrow just cannot produce enough red cells. Okay, it's an underproduction. The patient's going to have an abnormally high or an inappropriately normal or low reticulocyte count. Okay, so they're going to be anemic, but their retic count is not going to be elevated. Remember, I talked about the reticulocyte count, and anytime there's blood loss, it stimulates production of red cells. And so those immature cells, those reticulocytes, there should be a higher number of them. Well, in patients with hypoproliferative anemias, the reticulocyte count is going to be either normal or low because for some reason the body is not being stimulated to produce new red cells. Okay, so reticulocyte count will be normal or low when it should be really elevated. Can be, damage to bone marrow from medications, bone marrow suppressions from medication, or a lack of iron, B12, folic acid, like I said, decreased erythropoietin production. That can be from kidney dysfunction, kidney failure. B12 and folic acid can be from liver dysfunction. So, anything that disrupts any of those red cell producing processes can lead to a hypoproliferative anemia. Hemolytic anemias are premature destruction of the red cells. That leads to hemoglobin becoming free in the plasma, which leads to increased serum bilirubin levels. So I think the page number here in the chart, I don't know, the page number I don't think is correct. The chart number is right, 33-1, but I don't think the page number is correct. And I don't have it written down on my notes. Sorry. Causes of hemolytic anemias can be a problem with the red cell itself. It's just not forming properly, or it is misshapen or something like sickle cell. It can be, hemolytic anemias can be a problem in the plasma. There can be an immune response that is causing the red cells to be destroyed, or it can be direct injury to the red cell, which we would see in cases of a mechanical valve where that mechanical valve is actually chewing up or destroying those red cells. As blood moves through the valve in the heart, it just destroys the cells. So in cases of hemolytic anemia, we've got premature destruction of a good normal red cell, and it causes an increase in serum bilirubin. And then in hemolytic anemias, that reticulocyte count will be elevated because the body, there's a loss of blood, there's a loss of red cells, and so the body is stimulated to produce more. So it's not a problem of production. So there's an increase in the reticulocyte count. And then, of course, other anemias, not hypoproliferative, not hemolytic, just regular other types of anemias are typically most often due to just direct blood loss from trauma or, a GI bleed or something like that. It's just, an absence of enough red cells. Manifestations, of course, in your physical assessment findings, you're going to see that the patient is tired, they're weak, general malaise, they could be pale. In hemolytic anemias, they're going to be jaundiced because we have that increase of hemoglobin, free hemoglobin, leading to increased bilirubin. They may manifest with cardiac and respiratory symptoms, meaning chest pain, signs of decreased perfusion, shortness of breath, syncope, tongue changes. In our iron deficiency anemias, we see that the tongue can become very smooth and red. Nails can become brittle. The patient might develop pica, where they eat. It's an abnormal craving for strange things, ice, dirt, starches, just all kinds of strange things that the patient will crave when they are iron deficient. So, and I think y'all might talk about pica some in women's health, because it's not uncommon for pregnant women to develop iron deficiency and then they develop a pica that goes along with it. So make sure that you kind of review all of these assessment findings. Some important things to remember here: how fast some things that influence the development of symptoms. Okay, so how symptomatic your patient is going to depend on 4 things, really. How fast did the anemia develop? The faster it develops, the more severe your symptoms are going to be. Okay, and that's just because the body does not have time to compensate. Red cell production, that process of erythropoietin being stimulated and red cells being formed, that's a 5-day process, remember. So the faster the blood loss, the more symptomatic the patient will be, because the body cannot keep up. It cannot make cells as fast as it's losing it. Okay? And the body doesn't have time to adjust to that lack of hemoglobin and the lack of oxygen, so they become very symptomatic quickly. The second thing that's going to influence symptoms is the duration of the anemia, meaning how long has the patient been anemic. Chronic anemias, patients with chronic anemia will be more symptomatic. So the longer it's been there, or the longer it progresses, the more symptomatic the patient becomes. So patients with long-term anemias will become more symptomatic over time. The third thing that influences symptoms is the metabolic requirements of the patient. The more active they are, the more symptomatic they will be. The more physical demand, physical need that they have, the more symptomatic they will be. So if a patient is anemic, we want them to reduce their energy expenditure. Now, I'm not saying we want them to be sedentary or we don't want them to be active in any way, shape, or form, but we certainly don't want them to go run a marathon. We want to reduce energy expenditure. We want to reduce the amount of oxygen metabolic demand. Okay? And then the fourth thing that's going to influence your symptoms are your other comorbid conditions that the patient might have. We've talked about this too. Do they have cardiac or pulmonary problems? Do they have renal failure? Anybody with comorbid conditions will be symptomatic with higher hemoglobin levels than a patient with the same hemoglobin level who is healthy. What do I mean by that? You and I are healthy. We might, for some reason, become anemic and have a hemoglobin of 10. And you and I, because we are healthy, we will not be symptomatic with a hemoglobin of 10. Even though that's not normal, you and I might not even know, we might not be symptomatic at all. If you have a patient with renal disease, reduced ejection fraction, COPD, or all of those things, they become anemic and have a hemoglobin of 10, they will be very symptomatic because they have less reserve capacity. They have less ability to compensate. And so they will be symptomatic at a higher hemoglobin. You and I, when we're healthy, we're not symptomatic at 10. It might be that you and I don't develop any symptoms until our hemoglobin gets down to 7, maybe 6. But for the person who has comorbid conditions, they become symptomatic at 10. If they were to drop to a 7 or a 6, they would most likely be almost dead. So that's what I mean by will be more symptomatic at a higher hemoglobin level. Okay? When we're talking about anemias, it is essential that you look at the patient's comorbid conditions. Diagnostic testing, of course, CBC, H&H, and then a CBC with differential or reticulocyte counts, iron, B12 levels, folic acid levels, bone marrow biopsies, and then any other testing that might be done to identify sources of bleeding, stool for occult blood. Sometimes we do occult testing of gastric secretions if the patient has an NG tube or something like that. EGD, colonoscopy, diagnostic laparoscopy, anything where we're going in and looking for a source of bleeding, okay? And then our complications can include, of course, heart failure. For severe anemias, that would be a loss of hemoglobin. And then our paresthesias is the result of our B12 deficiencies, and then the delirium from low oxygen, low hemoglobin, of course, MI from low hemoglobin, low circulation leads to ischemia, and then that can lead to MI. So as you're thinking about anemias and the lack of hemoglobin, I want you to really relate hemoglobin to oxygenation and how the lack of oxygen can impair. We have talked about that all semester long, about how the lack of oxygen impairs these different organ systems. So how does it affect cardiac output? How does it affect mean arterial pressure? How does it affect oxygenation, ventilation, perfusion, renal function, all of that kind of stuff. Medical management, of course, is going to be to control the bleed or correct the problem, transfuse blood if necessary, give back whatever is missing. If it's specific to the type of anemia that it might be, can be B vitamins, can be iron, could be folate, and that can be done through diet therapy teaching, dietary teaching about dietary habits, or taking vitamins and supplements, possibly giving the patient not just a transfusion, but injections of epigen to stimulate production of erythropoietin. So, don't just, whenever we're talking about a significant anemia, you shouldn't just automatically go to diet, okay? Because remember, typically iron deficiency is not dietary. Usually an iron deficiency is the result of blood loss. So yes, they need to be eating properly, but we're not going to correct a severe anemia with diet therapy, okay? So you got to think beyond that. Age-related considerations, you also have to take into consideration, incidence and effect on older patients. Again, they're going to be probably more symptomatic at a higher hemoglobin, just because they're elderly and they have less compensatory mechanisms. And then if you have comorbid conditions on top of that, you have to take all that into consideration. All right, so in terms of our nursing process, our assessment, what are we looking for when we're talking about a patient with an anemia? What are we assessing for? Health history, physical exam, past procedures, past surgeries, what kind of history, other comorbid conditions do they have, physical assessment findings, skin color, cap refill, signs of perfusion and circulation. We're going to be looking at our lab data, asking them about symptoms, when was onset, how long has it been, what is the severity of those symptoms, is it interfering with their lifestyle, a nutritional assessment, what is their dietary intake, what are their dietary habits, does that include a healthy, well-balanced diet, alcohol intake, is a very significant thing to assess for, because we do see in a lot of our iron deficiency, B12 deficiencies, that these people are heavy drinkers. So you always want to assess alcohol intake and then recreational drug use too, because that can lead to malnutrition. Want to assess the types of medications that they're on. Definitely want to be looking at high-risk groups in terms of elderly for nutritional assessment and medications, and then in terms of high risk for iron, B12, folic acid deficiencies, children, lower socioeconomic areas, children of low-income families where meals, food may not be readily available. Vegetarians, we've talked about vegetarians too previously, about how they can be B12 and iron deficient. Alcoholics, I just mentioned. So make sure that you're doing a thorough nutritional assessment, and then age-related assessments as well. Looking at cardiac and GI systems for signs and symptoms, increased workload of the heart, chest pain, shortness of breath, tachycardia, orthopnea, signs of heart failure, signs of GI bleeding, just differentiating between the dark coffee ground and bright red blood, upper GI bleed versus lower GI bleed, dark tarry stools or bright red blood. So make sure you review those. Other sources of blood loss can be, GI, obviously GI bleed. And then women of childbearing age who have heavy cycles every month. There are patients who actually do drop a gram or two in their hemoglobin every month just in their menses. So asking women about their menstrual cycle, how many days, How heavy? How many pads are they soaking? How many tampons are they using? Those things are very relevant and very important when we're looking at a woman of childbearing age who is anemic. And then, of course, neuroassessment, we're looking for neurologic deficits, not just mental status changes, but paresthesias, numbness, tingling. Those can be signs of the peripheral problems can be pernicious anemia because that affects the central nervous system and the peripheral nervous system. So mental status, of course, would be any kind of mental status change could be from lack of oxygen, low hemoglobin. But, you also want to assess those peripheral nervous system changes as well. Our interventions, of course, are going to be to monitor and assess for our signs and symptoms. Sometimes these symptoms can be profound even though the hemoglobin is not low enough to require a transfusion. So you've got to really think about, as nurses, what can we do to help this patient, conserve energy, balance rest and activity, group our activities together, maintain adequate nutrition, teaching about proper intake, limiting alcohol, just all of those things to manage fatigue and, helping them live in this anemic situation, especially if we're not going to be transfusing them. Definitely individualize the care, individualize the teaching specific to the needs of the patient. And then we're going to be doing other things to maintain perfusion, giving them oxygen if necessary, blood transfusions if indicated, teaching them about blood transfusions if we're going to do one. We might be teaching about compliance with medication therapy. This might be iron therapy, epigen if we're doing to stimulate red cells, teaching them about how to take the medicine, when to take the medicine, side effects of the medications, potential complications, what needs to be reported, when does it need to be reported, when do they need to seek help, teaching them reportable signs and symptoms of heart failure, of peripheral problems, numbness, tingling, side effects of the medicine and how to deal with them. Iron therapy. Don't take on an empty stomach because it can make you sick. It's going to make you constipated. It's going to change the color of your poop, so don't freak out and think you're bleeding. Just a lot of little things that just make it very relevant to the patient. Okay, so hypoproliferative anemias. Think about what they are: underproduction of red cells. These are some of the most common, or some of the ones, not the most common, but these are some of the hypoproliferative anemias. Iron deficiency anemia, anemias of renal disease, anemia of chronic disease, megaloblastic anemia, including folic acid deficiency and vitamin B12 deficiency. Iron deficiency anemia is the most common anemia that you're probably going to see. It's just not enough dietary iron to replace what's being depleted, okay? And remember, I told you that iron deficiency anemia is most often the result of bleeding, okay? And because of the bleeding, there's a loss of blood leads to liberation of the iron stores to make more red cells, and the body, just regular dietary intake is not enough to replace the missing iron in this situation. So we've got to increase iron replacement, not just dietary iron, but a lot of times they'll get iron supplements or iron transfusions. The anemia of renal disease is just a lack of erythropoietin because the kidneys aren't functioning properly. Anemia of chronic disease has to do with rheumatoid arthritis, cancers, chronic infections, any kind of chronic disease It has to be a chronic disease that's been diagnosed and treated too, so before that anemia will get better. Okay, so that's kind of what that is. Megaloblastic anemia has to do with an abnormally large, or red cells that are abnormally large. And the way to treat those are, because usually they're folic acid or vitamin B12 deficiencies, and so you would just increase dietary replacement of those elements. Hemolytic anemias, the only one we're going to talk about is sickle cell. Hemolytic anemias just means, like I said, that the red cells have a shorter lifespan, so that the actual number that's in circulation is decreased at any given time, and that leads to less oxygen, which leads to hypoxia. So the only one that we're going to go into, like I said, is sickle cell, which is a genetic form of anemia that is a very, very severe hemolytic anemia. It comes from an inherited gene, has to come from two parents that have the sickle cell trait. Okay, so if one has it and one doesn't, then I'm not getting into all the genetics, but if both parents are carriers, then their offspring will have sickle cell. Okay, so a lot of people can have sickle cell trait, and that just means that they are a carrier, but they don't actually have the disease. Okay. Sickle cell causes the hemoglobin molecules to become misshapen. They actually will become sickled or curved shaped when they're exposed to, in venous blood, low oxygen tension. So venous, whenever the hemoglobin molecule is in the venous system, it is void of oxygen, then those hemoglobin molecules become misshapen. And when this happens, the sickled cells actually will stick to each other. And then that reduces blood flow. It creates almost like an embolus type situation. It leads to ischemia of tissues because blood flow isn't good enough, circulation is poor. And this is mainly in small capillary areas. Okay, so things like fingers and toes and the smaller structures of the blood vessels leading to organs and small capillary areas. Okay, but it reduces blood flow, so it can lead to ischemia, an actual infarction of tissues. It can be a region of the body, or it can be an organ of the body, but it leads to pain from the lack of blood flow. Ischemia meaning no oxygen. When we talk about the heart, we talk about the coronary arteries being ischemic. It leads to chest pain. The key here is that any part of the body that is ischemic, there will be pain. Okay, so sickle cell disease is a very painful process. It also leads to fever and swelling. There is an element of inflammatory process that happens. So it's just, it's not a pleasant experience. There is clumping of these sickled hemoglobin molecules. It's intermittent. It depends on the amount of oxygen that's present in the system at any given time. The clumping is triggered by things that reduce blood flow or cause constriction of the vessel. So that would be like cold temperatures, vasoconstriction, shunting of blood. So anytime that there's reduced blood pressure or anything that causes vasoconstriction, it could cause this clumping to happen. but it's, cold weather is especially known to trigger. Times of stress are known to trigger. So it's important for us to be aware of this when we're dealing with patients with sickle cell. It's also important to know culturally that it is primarily inherited in people of African descent, but it is also known to be present in people of Mediterranean descent. So, a lot of times people want to say that sickle cell is only in African Americans, and that is not true. There are many Caucasian people of Mediterranean descent that are being found with sickle cell now. So, just because somebody, a Caucasian patient tells you they have sickle cell and you're going to say, oh, they're crazy. No, you can't do that because it is known that people of Mediterranean descent can have it. Certain manifestations of sickle cell disease, the symptoms are very cyclic in nature, meaning they're intermittent, they're going to come and go. They will have crisis, sickle cell crisis, it'll resolve, they'll be okay, and then it'll trigger and come back again. The symptoms do result, complications result from chronic hemolysis or thrombosis. So again, sickle cell is a hemolytic anemia, so it is premature destruction. Okay, so our complications come from the hemolysis or thrombosis from them sticking together. These patients are always anemic. They usually live anywhere from 7 to 10 hemoglobin all the time, and that's just because their red cells have such a short lifespan. They are very prone to be jaundiced, and they are susceptible to infection, very susceptible to infection. Especially pneumonias, osteomyelitis. They are also very prone for stroke, renal failure, heart failure, pulmonary problems, dysrhythmias, cardiomegaly, things that are going to result from lack of oxygen to primary organs, or ischemia, dysrhythmias, ischemia of the heart, anything that's related to a lack of oxygen, okay? Sickle cell crisis is what we term an actual event or flare-up, so to speak. Sickle cell crisis is extremely, extremely, extremely painful. Results from hypoxia in the tissues and actual necrosis of those tissues from lack of oxygen. And like I said, it can be brought on, triggered by cold temperature. So it's important to teach the patient to protect themselves. Any organ can be affected by sickle cell. The primary sites are typically the spleen and the lungs, and then the central nervous system, because these areas, there's lower, or they're areas of slower circulation, meaning less oxygen. So, that's kind of why you see these areas being affected the most. Assessment diagnostic testing that we're going to do, of course, is CBC. We're going to be looking at hemoglobin levels. And then there is a process called hemoglobin electrophoresis, which is just used to confirm the presence of the sickled cells. Most of the time, diagnosis is made very early on in childhood. People that are affected by sickle cell disease typically begin to crisis by the time they're 2 years old. So, you've got very young kids who are having pain and can have circulatory oxygenation issues at a really, really young age, okay? So keep that in mind. In most cases, life expectancy, according to the book, life expectancy is, less than 50 years of age. And that's typically because of the complications that develop. These people go into renal failure very early. They develop heart failure very early on. So, a lot of times they have bad outcomes just because of the complications of sickle cell, the comorbid problems, but they don't have a very long life expectancy. Medical management, of course, is just aggressive management of the symptoms and complications. We definitely want to, treat those, manage the symptoms, pain, give them oxygen, things that are going to promote vasodilation and better oxygenation. Possibly do stem cell transplant. It's a possible cure, but a lot of times it's not an option for patients because many of them just have too much organ damage, and so stem cell transplant's not an option. Pharmacologic therapies, we can use Hydrea, which is a chemotherapeutic agent. Can be used. It has been used successfully with sickle cell, but the problem is because it's a chemo agent, it causes a decreased white cell count, which makes them more prone to infection, so you're kind of defeating the purpose. Transfusions can be given in acute exacerbations to help increase the amount of good hemoglobin, not misshapen hemoglobin, so that is an option. But then you're looking at long-term transfusion therapy and the problems that come along with that. And then just basic supportive therapy you're going to see in these patients is daily folic acid, iron replacement. That is essential that they have good folic acid levels because folic acid is the foundation of a good red cell. And then other things like prevention, infection prevention, making sure they get a flu shot, they get a pneumonia shot. They know how to protect themselves from respiratory infections, that they know how to report signs and symptoms of potential complications, heart issues, lung, kidney, all of that, that they know how to, they know signs and symptoms to look for, and, that they know what to report. Other supportive therapy, of course, includes pain management, and that is a very important part of medical management, but it's also can be very tricky because, like I said, these patients often they start to crisis by the time they're 1 or 2 years old. So these people are on pain medicine, lifelong pain medicine. So they do develop a tolerance. A lot of times as medical people, we are guilty of just labeling patients that come in wanting pain medicine. We label them as drug seekers. And with patients that have sickle cell, it's really hard because they crisis many times in a year. And so over time, they're going to learn what works for them. And yes, sometimes what works for them is a narcotic, and a specific narcotic. So they might come in and they might ask for a specific narcotic by name. And we owe it to them to not jump to conclusions and label them as drug seekers. Some of the basis for care of these patients can be aspirin or NSAIDs. Aspirin, works good for mild to moderate pain, but really the key here is that it has that antiplatelet effect. It helps to prevent those clots from forming, reduce the inflammatory process that goes along with it. So aspirin is a really good, even a daily maintenance thing, just to kind of help to try to keep them out of crisis. NSAIDs work for moderate pain, but they have kind of a ceiling effect, meaning that higher doses don't lead to increased pain relief. And plus you have to watch with NSAIDs, you kind of have to really watch renal function because NSAIDs are hard on the kidneys. They can lead to acute renal failure. and these patients are already at risk for renal failure, but a lot of times they think the more they take, the better it's going to, the more effect they're going to get. And with NSAIDs, that's not the case. The more they take, the more damage they do to their kidneys. Morphine, opioid, drug of choice, narcotic drug of choice for sickle cell, for acute pain relief, because it not only helps with pain, but it also dilates, which helps to improve blood flow. Kind of the same concept in sickle cell as it is with MI. Their chest pain comes from lack of blood flow. Same thing with sickle cell crisis. Their pain comes from decreased blood flow. So if we give them morphine, we vasodilate, we improve blood flow, and it helps to reduce the pain. But it is an opioid, it's a narcotic, it's addictive, and it has that potential for respiratory depression. So we have to really monitor for that. Oral hydration is a key part of management of sickle cell. Supplemental oxygen is also very helpful. It's very important that these people stay hydrated. Some alternatives or non-pharmacologic methods for pain management are important. It's important for us to educate and do repeated education with these patients, especially as they age, the elderly population, and just let them know, we may not get you completely pain-free. We're going to do our best to help you. We're going to do our best to reduce your pain and get it under control, but being completely pain-free may not be a realistic goal. So we may have to really reemphasize non-pharmacologic measures, heat therapy, which helps to vasodilate, therapeutic massage, distractions, guided imagery, and then support groups. Sickle cell support groups are important. Our responsibility with nursing responsibility with pain management, of course, is assessment, assessing the pain objectively, treating the patient objectively, and then reassessment for outcome. Our goal is to maximize patient functioning, getting their pain under control, but being able to maximize their functioning so that their pain doesn't disrupt their lifestyle. Infection prevention, again, is a nursing consideration, just encouraging them to do flu and pneumonia vaccinations and stay away from sick people and know what signs and symptoms to report. Just advocating for our patients and encouraging them, being supportive and helping them with their coping, talking about, their fear, powerlessness. I know they're with chronic pain. There's a lot of teaching, a lot of education that goes along with chronic pain patients, and they are considered chronic pain patients. And then a lot of education about complications, preventing DVTs and leg ulcers and signs of reduced circulation and problems. A lot of times with men, you have to really watch out for priapism. And then as they age, not even age, but even into their 30s and 40s, they can have problems with sexual dysfunction, and that can be very disturbing. And then, of course, chronic pain and substance abuse. So as nurses, we have to really make sure that we are assessing objectively and supporting and advocating for our patients as much as possible. Okay, next thing we're going to talk about, moving out of anemias, is neutropenia. We're going to be getting into our white cell dysfunctions. This is classified as a neutrophil count. And remember, neutrophils are a specific type of white cell, but a neutrophil count of less than 2,000, and it results directly from an underproduction or increased destruction of white cells, of neutrophils specifically. There is a great risk of bacterial infection as our white cell count decreases, or as the neutrophil count decreases. So as the actual number of neutrophils is reduced, our risk of infection increases. The infections can come from outside or inside the body, exogenous or endogenous sources. Exogenous is the world around us, and endogenous sources, primarily the GI tract and skin, are your common sources. An ANC, which is an absolute neutrophil count, is obtained from a CBC with a manual differential. That's where they look at the actual number of neutrophils that are in the smear. Okay, so an ANC is a very specific way to diagnose neutropenia. The risk of infection increases over time, so the longer the neutropenia is present, the greater the risk of infection. Even if the neutropenia, even if the level of neutrophils is not very low, the longer it stays low, the greater the risk of infection. And that's just because they have a longer exposure time. And the key here is that there are no clinical symptoms of neutropenia. People don't know they're neutropenic until they have an infection. And a lot of times that infection presents as sepsis. So, really the only way to diagnose it, the only way that you know that a patient is neutropenic is to see a CBC, to see a neutrophil count. And we don't just walk around doing neutrophil counts all the time because we feel like it. So this is kind of one of those hidden, silent processes. Medical management of neutropenia depends on the cause. If it's medication-induced, which a lot of times it can be, of course, the treatment is to stop the medication or whatever treatment is causing the bone marrow suppression or causing the neutropenia until the bone marrow can catch up. If it's an immunologic problem, such as immune system, rheumatoid arthritis, it's often from corticosteroid administration. So you have to weigh the risk versus the benefit of stopping the steroid. Sometimes treatment or medical management, they can give growth factors to help stimulate production of neutrophils, just to kind of boost production. But you kind of have to kind of weigh out what the cause is, in terms of how they treat it. In any case, a patient who is neutropenic and they present with fever, they're always considered infected, okay? And they're going to be admitted. They're almost going to be considered septic because, remember, with no neutrophils, they have no ability to fight off infection. And so for them to be running fever, that's a bad sign. So they're going to get admitted. They're going to have all kinds of cultures. We're just going to, kind of look at everything and start them on broad spectrum antibiotics until we find the source. Nursing management, of course, is assessment. We're looking at the signs and symptoms that are going to indicate how severe this neutropenia is. We're going to be looking closely at our CBC, following levels, seeing how our treatments are working, if those levels are coming up. We're going to be taking active measures to prevent any kind of complication, any infection, especially sepsis. Make sure that you look at page 920. It is chart 33.7, not what's on the slide. Page 920, chart 33.7, talks about neutropenic precautions. So make sure you review that chart very closely and are very familiar with neutropenic precautions and what's allowed and what's not. Just a lot of patient education. What exactly they're dealing with, how susceptible they are, what kind of self-care measures do they need to be aware of and make sure that they implement, when to seek care, how to seek care. A lot of times these people are not going to show these normal signs and symptoms of infection and inflammation, even just basic inflammation, redness, swelling, things like that. Without neutrophils, they're not going to have these basic signs and symptoms. So we have got to really do some good education with them. They need to understand that their only sign may be a fever, and that is a very late sign. Remember, fever means they're already infected. So, we've got to do a lot of thorough teaching with them. Okay, thrombocytopenia. Thrombocytes has to do with clotting or platelets. And so thrombocytopenia is a low platelet count. And again, that can be from decreased production or increased destruction or consumption of platelets. Normal platelet count is 150 to 450,000. Anything less than 20,000, we're going to see things like petechiae, can have nosebleeds, have bleeding in the gums. Counts less than 5,000 can result in spontaneous hemorrhaging in the central nervous system, which would be like a head bleed, definitely in the GI system. So, these are the people that you're going to see having upper or lower GI bleeds. When their counts get down that low, that can be a potentially fatal scenario when their platelet count is below 5,000. Make sure and review page 922, table 33.3, talking about thrombocytopenia. And just keep in mind that the risk of bleeding increases not only as the platelet levels drop, but if the patient is on any kind of medication that alters platelet function, aspirin, our newer ones, Brilinta, Plavix, those things, if they are on any of those kinds of medicines for whatever reason, and their platelet count drops, not only do they not have enough platelets, but what they do have don't work. So it really puts them at a very, very high risk of a very severe bleed. And again, they can still have significant bleeding, even if their platelet level is normal. They can still have a significant bleed if they're on antiplatelet medications. So again, make sure you're looking at this chart 33.9 on page 925, and that kind of goes into some issues with patients who are on antiplatelet medications. Make sure you review all of that. Our medical management is just to treat the underlying cause. Doctors are going to be looking at what caused it, possibly giving platelet transfusion, and then, if necessary, doing a splenectomy. And then as far as our nursing management goes, it's all geared toward bleeding precautions, which you should, kind of already have a good concept about. But on page 921, chart 38.8 goes over some of the basic bleeding precautions, so make sure you review that. DIC, we talked a little bit about DIC in class before, but again, DIC is not a disease process. It is the sign or a symptom of an underlying problem. It is generally triggered in cases of shock, sepsis. It can come from trauma, cases, trauma surgeries, trauma, motor vehicle accidents, allergic reactions. There's a lot of different things that can trigger it. It's an inflammatory response that is the result of an underlying disease. Whatever that situation or whatever that underlying problem is, initiates this massive inflammatory response that begins to create clotting within the blood vessels, little micro clots that begin to form within the vasculature. And as these micro clots begin to form, the body recognizes them and begins to initiate the normal anticoagulant process that it would generate anytime a clot is formed. And so it begins to release little anticoagulant factors, fibrinolytic factors, anticoagulant pathways, whatever. It's hard. Sorry, guys. It's really hard to explain, but this is exactly what you see on the slide is what happens. Inflammatory response initiates clotting within the vasculature, coagulation. The body responds with natural anticoagulant pathways, and then those processes become interrupted or impaired. The fibrinolytic system is kind of shut down, and then microclots develop. Okay? And so as the result of these microclots, the body's response is to try to dissolve these clots, these microclots, and in the process, all of the body's the platelets and the clotting factors all get used up. The body has no ability to clot. The body is trying to, there's clotting going on and there's anticoagulation going on. All of it's happening at one time. And as a result, the patient just ends up having paradoxical bleeding, okay? Ends up making these microclots. And then the body tries to take care of all of that. All of our clotting factors are eliminated in these microclots or used up in these little microclots. And so the patient just begins to frankly bleed from any place that we have stuck them, okay? So initially, you might only see a decreasing platelet count if you even have lab that shows that, that you've done lab in that time frame. But as it progresses, the patient just begins to have frank bleeding from everywhere. Mucous membranes, IV sites, GI, GU. So that means nose, Foley, GI, bleeding. Eventually, they're going to go into multi-system failure because these microclots are going to impair circulation. And then they're going to hemorrhage to death, usually. Frank hemorrhage can develop very late. Doesn't take long to get there. But pretty much, once they begin to hemorrhage, they've got about an 80% mortality rate. Our laboratory testing at this time, platelet count, PT, PTT, fibrinogen levels, D-dimer. D-dimer measures the amount of fibrin degradation. We talked about fibrin degradation product earlier in the lecture, and the D-dimer is the test that measures FDP. So if we have a lot of fibrin degradation product present, if our D-dimer is elevated, then that is a sign that there is clotting going on in the body and that the body's trying to break it down. So, these are all very important lab tests that can measure for DIC. You'll see a D-dimer done when they're trying to rule out PE, because a PE is a blood clot, usually. So, D-dimers can be used for other reasons, but it is also a very helpful test to have in times of evaluating for DIC. Our treatment is going to be to treat the underlying cause. It might be sepsis. It could be an allergic reaction. It can be, trauma or shock or whatever. So we just have to treat that underlying cause, try to correct any ischemia, restore circulating blood volume, treat the anaphylaxis, treat the sepsis, whatever the cause is. Of course, fluid and electrolyte replacement, try to maintain blood pressure and mean arterial pressure. Try to replace coagulation factors. We're going to be given FFP, cryoprecipitate, which is fibrinogen. We're going to be replacing those things. And then given heparin, like we talked about in class, in an effort to stop the body's clotting cascade, microclotting, we give an anticoagulant. to try to stop the microclot formation and improve blood flow to the organs and stop all that paradoxical bleeding. Our nursing responsibility here is just assessment of our patients for risk. So if we have a patient who's septic or has hypovolemic shock or something like that, we just have to be aware and anticipate that DIC is possible and do a frequent and thorough assessment for it. If you will review, this page number is probably not accurate, not positive. Y'all can verify it, but chart 3311, just to review your nursing interventions that would go along with DIC.